And I would like to introduce our moderator for today's presentation, Rhonda Omsler. Rhonda.
Good afternoon, everyone. On behalf of Education Service and the Ethics Committee, I welcome you to our first ever ethics simulation presentation. There was a need identified by the Ethics Committee on training people on what a real ethics consult is. So we all got together and decided to write a simulation and act it out for you and show you what it really is. I'm going to line up the scenario for you. It involves an 80-year-old female patient, and they are going to have an ethics consult to discuss the care of a family member. And I'm going to turn it over to Maria Taylor.
Good morning or afternoon, everybody. Thank you for making your way here in this lovely weather that we're experiencing. So we're going to start the scenario first, and the scenario will have the physician, the social worker, and two family members for the veteran, who is an 80-year-old female with acute kidney injury, likely end-stage renal disease, advanced dementia, late-onset schizophrenia, COPD, and aspiration pneumonia. So we're going to go ahead and allow them to take that away. Go ahead, guys.
Thank you, both of you, for meeting with us today to discuss your mother's care. Unfortunately, your mother's condition has not improved since yesterday. She has had massive stroke and continues to suffer from aspiration pneumonia. She continues to have what we call a delirium as a result of her medical conditions. Her kidneys also had stopped working. She is not swallowing effectively, and therefore it is not safe to give her oral nutrition or hydration. So overall, she does not have a good prognosis, and I think it is time to consider a different approach, different step for her care. I have reviewed your mother's advance directive and would like to honor her wishes. Have you reviewed them?
Do you know about advance directives? Is that where she leaves us her money and stuff? Why are we talking about this now?
No, it's not that kind of will. An advance directive is a legal document that includes a living will and health care surrogate. The document allows a person of sound mind to record their wishes for end-of-life care, plus select a health care surrogate. That is, someone to make decisions on your behalf should you become unable to do so. It is important for us to talk about this now due to your mother's condition and the situation at hand. Did your mom advise you that you were both her health care surrogates?
No.
I've printed copies for each of you.
Thank you.
Please take a moment to review them.
I can understand that this is difficult for you. I reviewed these documents with Ms. Goodall and your mom's primary physician, who discussed them with her when she had decision-making capacity about a year ago. Your mother recorded preferences about what she would want in circumstances like this.
Yeah, I see that, but I also know that my mother, and I know that she would want to have everything done to stay alive for us.
Upon reviewing her advance directive, she indicated that she does not want to prolong her life artificially. She specifically outlined that she does not want to go on dialysis, have PEG tube feeding, or hydration.
You can't be seriously saying that she is at the end of her life. I was having a conversation with her 2 days ago in the nursing home. She was fine. This is unbelievable.
It's apparent that you love your mom, and this is difficult for you both. Please take a little time to review the advance directive and digest what your mother's wishes were. We are here to support you during this trying time.
you know, we really want you to do everything that you can to save our mother. She's not ready to die yet, and we're not ready for her to die either.
This is because she is not on her psychiatric medications. Surely when she has been on her psychiatric medications for a good period of time, she will bounce back. This happened last time. She bounced back. I know she will. She's done this before.
I've followed your mother during previous hospitalizations and have done an in-depth chart review. In the past, she did not have the difficulty of swallowing or the problem with the kidney not working, and this is the case today. In addition, your mother has been on her psychiatric medications. She missed one dose when she was in the process of going to the ER. The change we are seeing in her mental status is a delirium due to her medical conditions. Unfortunately, it appears that she's not doing well and she is not bouncing back. I think that it may be time to consider caring for her in a different way. It may be time to focus on her comfort and make a referral to hospice.
Hospice? Obviously, I don't think you heard what we said earlier. We really want you to do everything possible to help our mother.
Okay, so what you've just seen there really is the beginning of an ethics consult. That reenactment of uncertainty is oftentimes present at the end of life or when there are other ethical dilemmas present, when there are a difference in values that are competing with one another. These types of situations, they unfold in our medical wards, they unfold in the community, they affect the lives of the veterans that we serve, and they also affect the lives of those that support the veterans we serve. So it's important that we as professionals be able to recognize when these ethics situations are present so we know how we can respond to them. So each one of the characters that you just saw had values and beliefs that supported their opinions. It's really very important to honor those values and opinions and to explore them in full. So we're going to revisit this scenario a little bit later on after the presentation to kind of get a better idea of how our ethics consultation service can interact with that. Prior to getting underway, I would like to thank members of the Ethics Consultation Service, Preventative Ethics, Ethical Leadership, and the Integrated Ethics Council members, because various members assisted with pulling this together, and this was no easy feat. So thank you very much, everybody. Thank you, team. Probably forgot to say that I have no conflict of interest and who I was. My name is Maria Taylor. I'm a licensed clinical social worker, and I am the co-chair of the Ethics Consultation Service. Our objectives here today are to identify the value labels that apply to a given ethics consultation request, request ethical dilemmas, recognize ethical dilemmas, and be able to utilize available resources, identify how to request an ethics consult, either through CPRS, the intranet, or telephone. So why do ethics matter to our healthcare organization? Unresolved ethical concerns can result in errors. They can result in unnecessary and potentially costly decisions that can be bad for patients, staff in the organization, and society at large, and poor employee morale, and burnout. If employees feel that they don't have an appropriate venue to express their ethical concerns, then that can lead to moral distress, which can lead to high rates of turnover and burnout. So an ethical organization, what does that look like? Well, it's one that has pretty good employee morale, high rates of productivity, pretty efficient, high rates of customer satisfaction, and we all know that that's very important, higher rates of employee retention, and there's a high quality of service there. This is the organization that I want to work for, and I'm certain that each of you probably want to get up in the morning and look forward to going to that type of organization. So in order for us to kind of understand how our ethics committee is perhaps part of a larger system and different from what you traditionally see in the community, it's important for me to give you a little bit of education about traditional ethics committees in the community. So, dating back to the 70s, that's when they started. In 1981, only 1% of the hospitals in the United States had an ethics committee. By 1990, the proportion rose to 60%. Then the Joint Commission came in 1992, and they basically stated that there needed to be a mechanism in place for considering healthcare issues in the care of patients. And by 1998, over 90% of the hospitals in the United States had ethics committees. That's pretty good, right? However, there are shortcomings of just having a traditional ethics committee. Ethics committees are not well integrated with other parts of the healthcare organization. So to illustrate this point, there was a study that was done, and they asked the chairs of ethics committees, tell me, what's the most salient ethics concern that you witnessed at your facility? Any guesses as to what these ethics chairs said? Come on, give me something, no? End of life, exactly, thank you. So end of life was seen as being the most salient. However, when they interacted with other members of the organization, there were systems issues that were of high concern, research ethics, and business management. So in traditional hospital settings, it appears that there was no one system to help integrate all of these ethical concerns that were detected. Traditional ethics committees lack a clearly defined purpose. So when a traditional ethics committee is asked to define their purpose, they often use phrases such as to provide a forum for discussion or to promote ethical reflection, which in and of itself is not a bad thing. However, a problem with such a description, when you're considering the entire organization, is that they don't explain the ethics committee's instrumental value to the organization or its mission, and furthermore, they're too vague and they don't lend themselves to measurement or improvement efforts. Traditional ethics committees lack quality standards and accountability. Again, no definition of quality management, evaluation, and there is generally little oversight. Traditional ethics committees have not evolved with the advances in the last 25 years. So healthcare organizations have certainly changed a lot in the last 25 years. There have been a lot of fields of study to include improvements with organizational studies, leadership and management theory, quality management and improvement, complex systems theory, social, cognitive, and cultural psychology, and human factors engineering. So it's often the case that traditional ethics committees have not kept up with these developments in these fields of study. Effective management of ethical issues in healthcare organizations is an intricate matter that requires a modern-day understanding of how complex organizations work and how they affect human behavior and experience. So, we have VA, or ethics in VA healthcare. VA has positively affected healthcare in the United States for a number of years and in a number of areas. So from the development of the decentralized electronic healthcare record to treatments of PTSD, TBI, and training 70% of our physicians nationwide, we make some pretty good contributions out there. So it was no surprise to me when I started down this path of ethics that I had learned what strides they were making in this area. They were really pioneering an effort to have ethics be very pervasive in the system and have a system of accountability, measurement, and proven strategies for organizational change. How many of you have seen this fine image? Many times, right? Okay. So ethics within VA is commonly illustrated with this iceberg. And at the surface of the iceberg lie easily observable decisions and actions and the events that flow from them in the everyday practices of the organization and its staff. Just below the surface, you can see the organizational systems and processes which drive decision-making. These organizational factors are not readily visible, and in and of themselves, they become apparent when one looks for them. For example, by examining patterns and trends in the ethics consultations. And at the deepest level lies the organization's ethical environment and culture, which shapes the organization's ethical practices. This level consists of values, understandings, assumptions, habits, and unspoken messages, what people in the organization know but rarely make explicit. This level is the foundation for all other levels. So as we spoke of earlier, traditional ethics committees spend much less time reacting to clinical issues and focus mostly on visible concerns. VA recognized that in order to have a viable and meaningful ethics program of high quality, the program had to be structured to routinely identify deeper organizational factors that influence the day-to-day behaviors which are easily observed. So the integrated ethics model embraces a comprehensive approach utilizing the 3 core functions, each of which targets a different level of ethics equality. So at the surface, this is generally what you see in the day-to-day operation, and you may notice that this is pretty much what the Ethics Consultation Service does. Just underneath the systems and processes, Ms. Doreen Apun, sitting right there, is the chair of preventative ethics. So whenever there is a systems or a process issue that perhaps can be looked at and improved upon to help our organization behave in a more ethical way, her committee looks at that. And then environment and culture, that's our ethical leadership headed by Ms. Klinker, and it affects the culture of where we work. So it was important for me to express to you how ethics is different here within the VA prior to moving forward. So for the rest of the presentation, we're going to focus on ethics consultation services. So the ethics consultation in healthcare is a service provided by an individual ethics consultant, consultation team, an ethics committee, and they're there to help patients, staff, and others resolve concerns in a healthcare setting. So very recently, we were able to add more members to our ethics consultation service. And I'm pleased to say we have 17 members right now, which is awesome. Don't worry, if you consult us, 17 people will not show up at your door begging to help you. That won't happen. Essentially, we will look at the issue that's in front of us and decide whether it's a single consultant that can manage this, if it's a team of specially selected people for their expertise that will respond, or if it is the entire team that's needed. So we do that on a case-by-case basis. We don't just stick with one method because it's not a one-size-fits-all. The goals of ethics consultations are to improve healthcare quality by facilitating the resolution of ethical concerns. The forum provided for discussion and methods selected for careful analysis enable effective ethics consultants to promote practices consistent with high ethical standards, foster consensus and resolve conflict in an atmosphere of respect, honor participants' authority and values in the decision-making process, and educate participants to handle current and future ethical concerns. So ethics consultations, as I mentioned earlier, are needed when there are competing values present. But in order to understand that, we really need to define what values are. Values are defined as strongly held beliefs, ideals, principles, or standards that inform ethical decisions or actions. Values describe what is valued from an ethical perspective. And some examples of values, and we'll not read them all to you. I do not wish to put you to sleep. There are pages and pages of values out there. I chose the ones that are really the most present when we do the ethics consultations. So we'll see a lot of non-malfeasance, altruism, beneficence, benevolence. We see a lot of those. What'd you say, guys? I like my team up here, too. This is very nice. So the Ethics Consultation Service handles case consultations as well as other types of consultations to include the list I have before you here today. I'm going to give you an example of one of these. So we had a request for general information, but it came in disguised as a consult. We had a physician that contacted us. He was serving a veteran who was 100% service-connected for a medical condition. The veteran lived overseas, and he did not have the means to travel to and fro numerous times per year, as was mandated by the treatment he was getting. He needed to have blood work and have some oversight. And so the physician was torn because he wanted to serve this veteran, but he didn't know how he could do that without doing the blood work to make sure that he was well and safe. So he contacted us because he was concerned about that. And it made its way over to me, and I was aware of the Foreign Medical Office that handles those types of concerns. So if somebody is service-connected for something and they're living overseas, that office can help facilitate the treatment of that condition. So that was an example of general information given. So we can function in that realm as well. If you're ever interested in placing a consult with us, you can do so by going to our intranet. We have our wonderful ethical button, which Monica, who has done a great job with the necklaces, she can give you one so you can take it with you and always remember. You can push that button. The email will go to Mr. Barron, our Integrated Ethics Program Officer, and you can state your concern. And he'll route that to the correct place. The second way to place an ethics consult is to go through CPRS and choose the ethics option under miscellaneous, and that should be present also under inpatient as well as outpatient. And then the third way is that you can call one of us. If you're not sure if it's an ethics consult, if you just need to talk about it, you can pick up the phone and give one of us a ring, and we'll be happy to speak with you about it. So the VA National Center for Ethics in Healthcare designed the CASES approach. It's a practical, systematic, step-by-step approach to ethics consultation. The CASES steps were designed to guide ethics consultants through the complex processes needed to effectively respond to ethical questions and concerns. The steps are intended to be used in much the same way that clinicians use standard format for taking a patient history, performing a physical exam, or writing up a clinical case. So I'm going to go over each of these steps pretty briefly with you just to show you what we do. So the first step is to clarify. So first of all, we need to know what type of case we're getting. Is it an active clinical case where people are here in the wards? Is it an active clinical case in the community? Or is it more of a question or a general inquiry for information? Because that immediately tells us who we need to pull together. We obtain the preliminary information from the requester. We want to know the who, what, why, when, where, how, and what's already been done to try to resolve the values that are competing. And that's important because it's important for the treatment team to try that first and resolve it on the lowest lying level prior to escalating that. And then we establish a realistic expectation about what we can do. Oftentimes people will come to us and they'll kind of go here, can you fix it? And we don't have magic wands. We can't fix things. We can't make treatment plans. We can't make people do something they don't want to do. But what we are there to do is to help you sit, evaluate the situation in full, and offer you guidance and support. And then one of the things we do in this step that's highly, highly important is formulate the ethics question. Much like research, if you don't have a great question that directs your efforts, you're going to be wasting a lot of time. So that's highly, highly important. The next step is assemble. So this is where, as a committee, we look at what information we need to gather. We'll always do a chart review if it's a clinical case. We'll do the research in our intranet and internet on scholarly sites to gather the relevant ethics knowledge. We'll gather as a team, review it all, and then what do we do after we summarize the case? We look back at that ethics question to make sure we got it right because, again, it's really, really important to make sure that it's correct. Then we move on to synthesis. Most of the time we elect to do a formal meeting. I think it's highly appropriate to pull in all stakeholders to talk about what their opinions are and what values are present. Oftentimes, people are so attached to their opinions and values that they have a hard time hearing what the other opinions, values, and perspectives are that are present. So it's very nice to be able to assemble that all together and allow everybody to witness everybody else's opinions and values. And through that process, that's where the moral deliberation comes in. It's done in an air of respect. And oftentimes, at the end of this process, there'll be a clear path of what the right thing to do is. Then is explain. If all the stakeholders are present in the previous process, usually they're there and they hear the explanation and they see it unfold. If for some reason they're not present, we'll contact them, we'll have the discussions, we'll call another meeting if that's what's needed. We also provide additional resources and then document the consultation. There's a national database called EC-Web, and that database basically has us document it step by step. It's very lengthy, but it's very thorough and beneficial. And the reason why it's beneficial is because it assists us when we go back and kind of evaluate what kind of consults we've been doing for the past 3 months, 6 months, 2 years. It helps us to identify if there are any trends. So if we have a trend in a particular issue and it's related to a systems or process, guess who I'm calling? Yes, I'll call Doreen. Or we'll take that issue to the Integrated Ethics Council meeting and talk about it there. So it's very important to do that. The other thing we do too during support is we evaluate ourselves. I think the first time we had done an ethics evaluation with some of the new members this year, I looked to the team and I said, so how did you think I did? What did I do right? What did I do not so well? And they looked at me like, what? But that's really important. Everybody needs to hear feedback about what their strengths are and what opportunities there are for improvement so that we can continually refine what we're doing and give a good product. we would be silly and foolish if we only asked ourselves what we did right and what we did wrong. So something else that we do is we also give the feedback evaluation tool to those that request the evaluation to obtain their perspectives of what it was like to engage with us and, again, what we could do better. So with all that information now in your brains, we are going to move back into the simulation. So at the table over here, we have Ms. Goodall, the social worker, and Dr. Smith, and they're going to be reviewing their interaction.
This is so difficult. I feel so bad for the veteran and her family.
I know. It is hard to see such pain in the end of life. I try to give them a real picture of what's going on, but I don't think they can hear me.
Yes, grief can do that. They might be experiencing some denial. They're not ready to let her go.
But keeping her alive against her wishes is something that I have issue with. Also, there is no chance for her to recover, in my opinion. The care we are providing is ineffective and could actually cause harm than good.
It is a difficult situation. We held the family meeting to provide the information, but they really seem to focus on keeping her alive. There are competing values in this situation. It may be a good idea to consult the ethics consultation team. They may be able to help.
The ethics consultation service, what are they going to do that's different than what we are doing right now? I don't want anybody telling me to change my treatment plan. Are you suggesting I'm unethical?
No, I'm not suggesting that at all. I value you as a physician. The ethics consultation service does not make treatment plans, tell people what to do, or investigate claims of unethical behavior. They are here to support and to help provide guidance in complex cases like these. They've helped us with a similar case last week using an approach that they referred to as the CASES approach. They identified the central concern, or what they call the ethics question. And this is so important because it focuses people on the main issue in order to move forward. They locate relevant ethics knowledge to ensure that we have the best information. The ethics team then evaluated the issues from everyone's perspective, the patient, family members, and the healthcare team, keeping the ethics knowledge in mind. They really get into looking at the ethical claims and counterclaims and reviewing the merits of each one. They then explain their findings to all the members involved, supporting the process as it unfolds.
Well, if you insist, we seem to be at a stalemate with the family. I guess we can ask them to look at this case. Let me call Dr. K.
Okay.
Dr. K here. How can I help?
Hi, Dr. K. This is Dr. Smith. We have a bit of a dilemma here on the MICU and could use the help of the ethics team with it.
Well, sure. I'll be glad to help. You're kind of in luck. I've got Norma here from our ethics team. Is it all right if I put you on our speakerphone so we can talk together?
Sure. Am I on the speakerphone now?
Let's see. Yes, you are.
Hi, Dr. Smith. We hear you loud and clear.
Okay. So we have an elderly female veteran, Miss Tibula, who has dementia and late onset schizophrenia. Recently, she suffered a massive stroke and her physical condition has deteriorated. She now has acute kidney injury, most likely ESRD, end-stage renal disease, because her kidney doesn't appear to be recovering. Also, she has aspiration pneumonia and a delirium as a result of her medical conditions. So overall, she does not have good prognosis. She has advanced directives in which she stated she does not want life-sustaining treatment if she has terminal conditions and it's not expected that she will survive. In the same document, she identifies her children as healthcare surrogates. It seems that she's not going to get better, and further treatment at this point is ineffective. However, the children, her healthcare surrogates, want to continue aggressive treatment. We are at an impasse and could use some of your assistance.
Wow, sounds like a tough situation. Our ethics team frequently deals with similar situations. Often the healthcare surrogates and family, they don't understand what's in the living will or even follow the living wills. Sometimes we need to bring in a third party to provide a forum and a discussion to fully evaluate the circumstances. Can you give me the veteran's last name and last four?
Sure. It's Tubula 1111.
Excellent. I'll assemble a team and we'll look at the case and then we'll get back to you. Are you able to meet tomorrow around 2 o'clock?
Yes, that will work. Thank you.
Yeah, thanks, Dr. Smith. Norma, looks like we've got a case.
Indeed. It sounds like the physician is valuing non-malfeasance, and this contradicts the autonomy of the healthcare surrogates. It also seems that this affects the autonomy of the patient, as the healthcare surrogates are wanting treatment that is different from what is listed in the advance directive. I think that the ethics question is, given that the veteran has an advance directive indicating that she does not want aggressive treatment at the end of life, and treating provider determined that she's at the end of life, is it ethically justifiable to honor her healthcare surrogate wishes of performing aggressive treatments?
Norma, you're getting good at this. I think that definitely is a central concern, and the question that you posed was well stated. This will help our team focus our discussion as we move forward with a structure and parameters.
Thanks, Dr. K.
We'll need to assemble the information from the chart and assemble all relevant ethics knowledge now.
Being a dietitian, I know that elderly with dementia may have poor outcomes when PEG tubes are placed. Let me search that information so that when we meet, we have relevant knowledge that will help to inform the ethics process.
Great. Let's do a full chart review now and for our whole team to comprehend the current situation. Do you think we should include the family during the meeting tomorrow?
Absolutely. The family should be present at this meeting.
Okay, I'll reach out back to Dr. Smith and advise them to have the family present if they're willing and able.
Okay, and now we're going to transition to that large family meeting, including the ethics team. So we'll get all actors to that square table, rectangle.
I want to thank everyone for being here today. Several of us are members of our ethics team, and we're here today because we have special training in ethics. Our role is to help when there's difficulties in reaching decisions because of differences of opinion or ethical uncertainty. Our team is here to assist, but not to dictate what's going to happen. We're here to offer support and guidance. We help with evaluating all options available in any given situation, and also to ensure that all people have a voice at this table. It's with this support that we as a team can honor your mother and having all the members move forward together in the best interest of your mother in mind. So with that being said, let's do some quick introductions and get started by gathering everyone's perspective.
Hi, I'm Charles, and this is my sister Eliza, and we're the children.
I'm Dr. Smith. I'm the attending physician.
I'm Dr. Jones, the psychiatrist.
I'm Karina Goodall, the social worker.
I'm Norma Miller, the dietitian.
And I'm Dr. K on our ethics team. So let's get started by hearing from the family. Eliza and Charles, in your words, can you express what goals you have in mind for your mother and what you think she might have wanted if she was here?
Well, Eliza, do you want to speak to that?
Sure, Charles. Well, we've been through a lot with our mother. She had late onset schizophrenia, and then that was complicated by early onset dementia. She has been in the hospital countless times where she wasn't responsive, and it always turned out to be due to her mental health. She always bounces back. I think she just needs an adjustment of her medications.
Charles, do you have any additional thoughts or opinions?
You know, I just really don't think that our mother is ready to leave us yet.
Charles, what makes you think that?
I don't know. It's just so hard.
It is hard, but that's why we're here to support you.
Thanks. She's always just said that she would be there for us.
Did the two of you ever talk about what your mother may want?
We didn't really talk about that. I guess we should have.
Many people don't have these discussions. You're not alone. Let's figure out what we can do to move forward with this and do what's right for your mom.
Eliza, you mentioned that you felt that this could be due to your mother's mental health condition. I've invited our attending psychiatrist to the meeting. Dr. Jones, can you provide your clinical opinion of Ms. Tibula's mental health?
Why, certainly. I've treated your mother on and off for numerous hospitalizations. In the past, we've seen a steady decline in her mental health over time prior to each hospitalization. During those incidents, she did not respond to medication adjustments. This time is different. She was stable with her mental health just prior to her stroke. What I'm seeing is a delirium caused by her medical conditions.
Well, what's the difference between a delirium and dementia?
Well, with the delirium, there's a sudden onset of confusion or a change in mental status. Until your mother had the stroke and pneumonia, she was pleasantly confused, but was able to get dressed, sequence easy tasks, and feed herself. Now that she has these conditions, she's not able to do any of these activities. Since she lost the ability quickly, and having that coupled with her illnesses, it can be determined that she is in a delirium.
In the past, she never lost those abilities. She would speak and it wouldn't make sense. I think I heard someone call it word salad one time. That stuck with me.
That would be when her thoughts became disorganized. Right now, she is delirious, not disorganized.
Yeah, Charles and Eliza, do you have any other questions or need any other clarifications from Dr. Jones?
No, I can see what he is saying and see the difference. Thanks for explaining that to us.
Thank you, Dr. Jones. So we've heard from the family and the psychiatrist. Now let's hear from the attending physician, Dr. Smith.
Thanks. So I had numerous specialists evaluate your mother, and I would like to go over each of her medical conditions now. Let's start with her kidneys. They shut down, and as a result, her body is unable to rid itself of waste. Initially, we thought they would recover, but it's been a week. I talked to the nephrologist, and they're not expected, according to them, the kidney is not expected to recover.
We were hoping they would recover.
We were too. Unfortunately, that is not what her body is doing. Dialysis can act as in place of the kidneys, but your mother indicated in her advance directive that she does not want dialysis. Also, with her age, advanced illness, and her current condition, she is not a good candidate, ideal candidate for dialysis. I think it might do her more harm than good. I also brought in a speech therapist to do a swallow study. And recently, there was a study that was repeated to see if there's any improvement, and there was no improvement. The only way to get nourishment to her is through a PEG tube, and this is something that, again, your mother stated in the advance directive that she does not want.
But our grandmother had a PEG tube and was in a nursing home for 3 whole months with it.
Why was your grandmother in the nursing home?
Well, she had dementia as well. It was difficult to go and visit her in the end. My grandma really looked miserable and very, very uncomfortable. It was really, really hard to see her that way.
I am sorry that you had to see your grandmother suffering in a deteriorating state. In addition to being on the ethics committee, I am also a dietitian. I pulled some relevant research on PEG tube placement in people with dementia. The literature shows that placement of a PEG tube in patients like your mother and grandmother may not result in keeping people comfortable or prolonging life. I can supply you with more information on this topic if you like.
I really didn't know that. Thanks, and it actually makes sense now because my grandma's last few months were very unpleasant for her. I would like more information, and thank you for offering.
I guess that leads me to ask you about the quality of life versus the quantity of life. What do you want for your mother, and what do you think she might want?
Well, all I know is that my mom said that she did not want to have things happen to her like what happened to my grandma. You know, she really would not want to live in pain or be a burden to us as children. This is really so hard. I really don't know what to believe. I don't really want to believe that this is the end of her life.
I think if there is a chance for her to recover and have a good quality of life, we should give her the PEG tube.
From what we've heard here today from the other providers, the prognosis for recovery is poor. Would you want to risk her level of comfort for such a small chance of recovery, or would you prefer to focus on comfort?
I think we have to discuss that as a family then. Right, Charles? Yes. I don't think either of us wants to see her suffer if she is not going to get better. We just hope she will get better.
We've reviewed your mother's conditions earlier in the conversation. Let me summarize. What I've heard here today seems that her recovery is not likely. The stroke was a massive one, and she will not be able to recover her ability to swallow. If she does get a PEG tube, she'll have some food and fluids that she's able to have, but she will not recover her ability she lost from her stroke. Her kidneys will not recover. These are all things you have to consider when you make a decision for her.
So if I'm hearing you correctly, you're saying that there's little reason to expect that she's going to recover?
I'm sorry to say, but that is correct.
Well, I guess that we knew that this was going to be coming one day. I just didn't want to believe that that day was today or that the time is now.
We've covered a lot of material here today, and I want to thank you all for being here. We heard a lot of information, and everyone's viewpoint was informative and valuable. Did you get all the information you needed from this meeting?
Yes, we have a very clear picture of what her conditions are and what her prognosis is. It was helpful to sit down and get all this information at once. I think we have some family discussions we need to have and some decisions to make.
Thank you. We want to be willing, we want to thank you for being willing to take part of this process. Do any of the team members have anything further to add?
Nothing more.
Will you be meeting soon as a family?
We have other family members coming in tonight. We will discuss her situation then. Dr. Smith, can you see us in the morning?
Of course. I'll stop by your mom's room around 9 a.m. if that's okay.
Yes, that will be fine. Ms. Goodall, can you come also?
Sure, I'll be there.
And that's scene. Thank you, guys. I appreciate you being willing to sit up there and do that. That was great. So this was loosely based off of a real-life situation that occurred. And shortly after this meeting, the healthcare decision maker sat back for a bit of time. I'm not going to lie and say it was just right then, but it was a bit of time. And the healthcare decision maker eventually made the call that it was the appropriate decision to involve hospice for the veteran's care. She was able to make that decision, though, in a supported manner and without pressure. She was afforded the opportunity to turn over every rock to understand everybody's perspective. And she was able to move forward knowing that that was the right decision for the care of the veteran. These types of situations are fueled by high emotion, and our service can help with tempering that emotion and focusing those efforts on the veteran and moving forward towards resolution. So that's what we were trying to get at through that scenario, and hopefully that's what was expressed to you. So in the interest of time, the cases approach that I reviewed, we didn't go through every painstaking step with you because there's no way to do that in that compressed amount of time. But that's, again, just an overview of what an ethics consultation might look like. So now we'd like to go ahead and start our panel discussion. So I'm going to ask that the ethics members stay put, or anybody that's speckled throughout the audience. Dr. Gonzalez-Mayo, who's a co-chair, come on down. We'll have any ethics member in the audience. Preventative ethics are welcome to come up, as well as leadership ethics if they'd like. And then we can engage in some discussion.
So I'm out here in the audience to get you to participate. So I'm going to give you a chance to volunteer. How many people in the room have used, have ordered an ethics consult or participated in one? Christy? Have any of you seen this process prior to today? How many have not seen this process prior to today or used it? No, you all have? Okay. So who has a question for our panel members on an ethics consult? Did any of what you saw today bring you new information?
Were any systems issues identified out of the scenario you used?
So I think that one of the systems issue that's prevalent for me whenever we see consults like this, and I think the team can speak to this as well, is that we need to do a very thorough job of discussing advance directives and also encouraging the veteran to not only identify who their healthcare surrogates are, but to go back and talk with their healthcare surrogates before they assign them that responsibility and make sure that that healthcare surrogate is able to follow through with what the wishes are. So that's kind of a systemic issue that was observed in that. Anybody else have anything to add to that?
Well, I think another thing was a lot of people, employees didn't know exactly how to do an ethics consultation. We've created an easier link as far as on the website. I mean, and you've done a lot of work as far as education of the employees, such as this presentation today, in order to help people and let them become more aware of the services that are available.
Thanks, Doreen.
So Maria, why don't you give the audience an example of an ethics consult that may have been ordered but really wasn't an ethics consult to help them learn the difference between the two?
Well, let's see. Alina, can I put you on the spot? Or I can come up with one, but I've done a lot of talking. I would say oftentimes, once in a while, we'll get an ethics consult where the treatment team hasn't spoken with the family yet, or they haven't consulted with social work. You know, on the medicine floors, social work's available by consult. They don't see every single veteran. So we've gotten a lot of those where we've asked the question, did you involve social work? Did you go back and talk with the family yet? And if they haven't, then we'll kind of guide them through what they should do first, and that if that doesn't get them where they need to be, that they can reconsult us. So that's pretty frequent.
Question. When at the beginning of the discussion, you said that both children were equal health care determinants for their parent, for her parent there. What happens in our health care directive? Shouldn't it be one child, then the next child, then the next child, then rather than making them equally responsible? Because that could lead into problems also.
On the advanced
directive.
On the advanced directive, there's the initial healthcare surrogate and the second. What we'll see is oftentimes when both of them are there and they're in agreement with one another, that's not a big deal because they're in agreement with one another. Occasionally they'll be at odds with one another, but it's the first healthcare surrogate, I believe, that takes precedence over the second. We would obviously consult with regional council and get their input with regards to that.
Christy, you said that you used the ethics team. Would you like to share your experience?
Actually, I was a member on the team, so I was doing a lot of ethical consults a while ago. Actually, in the beginning, before they brought on cases, that's when I was involved. And as we moved into the cases model, I think it's an excellent model, and the process and getting all of that integrated ethics up into the whole facility level, because it was initially just an ethics consult team that kind of went around and did clinical consults. So it's really nice to see how much the whole process has evolved.
Thanks. I think it is pretty important how that approach is used, because traditionally ethics committees, they are kind of an island unto themselves, and they keep the information they gather and don't necessarily share it. So it is nice to see that VA took a pioneering effort and that it's meaningful and that it's pervasive.
Sometimes it seems to take a long time before you see the consult answered in the chart. And, I can see it's probably related to this process. But when you're like a dietitian, you kind of look at it more urgently because you see the patient going by a week maybe without getting nutrition, or maybe it's going over a week. And I'm just thinking maybe it's a good idea just to call somebody directly.
You want to answer that? You should. So if there's a need for immediate documentation, let us know. The cases approach is a very lengthy, it's a lengthy documentation tool. We've gotten better since we went from 5 members up to 17. We've gotten a little bit better at getting that in there within a few days. If you do have a need for information, though, and it's not there, give one of us a call, and we'll be certain to give you the information we can and at least get comments added to the chart to make you feel more comfortable in what you need to do.
Like you guys present MICU case, and I don't know if it was real or no, but my approach would be different. And the thing is, why we're not involved in maybe at the time that you guys are meeting, or in this case, we have a nutrition support consult that we make a decision, just hold it until the ethical committee see the patient, and we never get the answer. We're just waiting for you guys to make the decision and then start a patient on
So-
any kind of nutrition support.
So whenever-
And I'm like, why, you know, I don't know. I mean,
If you've ever not been invited to a meeting before, that was probably an oversight, and I offer the apology right now. Anybody that's involved in the veteran's case, especially if it's nutrition, they should be invited to come to the table and sit and talk with all of the members present. We had an ethics consultation 6 weeks ago, and speech therapy was invited because they were the ones that did the swallow study. So if you have been excluded before, my apologies to you. We'll invite you in the future.
okay.
Okay?
I think a big mistake that people have with, and we get a lot of these consults, like a physician will put in a consult, well, I did this and this, and now I want the ethics committee to tell me what to do. And that is not our role. We're not there to tell you what to do. We're there to advise and consult, but not to tell you. That's the physician decision ultimately. And that's a very big misconception that people have with the ethics committee. I mean, I can't tell you where you're going to put a tube or not. That's not our decision to make. So we get a lot of those sometimes, and then we basically talk to the doctor and say, that's not really our role. You, as the treater, have to decide what to do.
Are there any other questions in the audience? Does the rest of the committee have anything they would like to add? No? So celebrate National Compliance and Ethics Week and come get a pamphlet and sign the banner back here.
Thank you guys all for coming.
Yes, thank you very much.
Thank